Bismillahirrahmanirrahim. This is Dr. Iram. Welcome back to my channel with second part of my lecture on RCT. In today's video, I will talk about the working length determination and canal preparation. So without any delay, let's jump into it. Now talking about the working length. Basically, working length is the whole length in which we are going to work, right? So working length is that part of the length in which we are going to do RCT. Working length is the distance from some coronal reference that could be incisal or occlusal point in the crown area to the point in the root up to which we are going to obturate the canal, that is 0.5 to 1 mm of the radiographic apex. Now I will discuss different techniques for recording working length. There are some radiographic technique and some non-radiographic techniques. The non-radiographic method consists of tactile sensation, periodontium sensitivity, paper point method, and apex locator. The first non-radiographic method of recording working length is tactile sensation. Although it may appear to be very simple, its accuracy depends on sufficient experience. An experienced clinician may detect an increase in resistance as the file approaches the apical 2 to 3 mm. Afterwards, the confirmation may be done either by the radiograph or electronic method by using the apex locator. This method has few drawbacks. That is, this method is unreliable as we cannot get same result every time. Also, it depends on the skill of the dentist. It is unreliable in open apex or root resorption. The second method of detecting the non-radiographic working length is by doing periodontium sensitivity method. This method is based on painful response from the patient when it reaches the working length across the apex and touches the periodontium with the K file. In this method, we intentionally cross the apex to reach the periodontal ligament and carefully watch the patient respond towards the pain. The problem with this method is that it gives false result in inflamed tissue. Pain might occur before reaching the apex, and in case of necrotic tooth, file may cross the apex without any pain. Paper point method. This technique is based on the principle of the wettability of the paper point. This technique includes placing a paper point in a dry canal 1 to 2 mm shorter than the working length determined by the electronic apex locator. If this point is dry, advance the paper point until it is just moist. A minute amount of blood or tissue fluid at the end of the paper point is an indication that the paper point has been inserted beyond the foramen. Repeated paper points are used to determine the wet-dry point to determine the working length. That is from the occlusal level of the tooth to the apex of the tooth. The next method of locating working length is by using apex locator. Apex locator works by using the body to complete an electrical circuit. This is apex locator that is used to locate working length. One side of the apex locator is connected to the oral mucosa through a lip clip and the other side is connected to the file. The circuit is completed when the file contacts the periodontal tissue at the cemento-dentinal junction. Now comes the advantages and disadvantages of apex locator. The advantages are it is easily operated, it can give you the digital readout, audible indication like if you put a file in it, in the tooth, it will start blinking. It detects the perforation. It can be used with K-file, may incorporate pulp tester. Disadvantages include that it is little sensitive procedure that required an isolated dry field. Patient might feel little sensitivity or irritated as the different devices are used in cooperation with this device. It requires calibration and good contact with lip clip. It cannot estimate beyond 2 mm of the apex. Radiographic method. Traditionally, the method of determining the working length is by taking radiograph with files in the canal. A good quality radiograph has to be taken using the paralleling technique with the help of an aiming device or image receptor holder. This technique is the most commonly used technique for exposing periapical and bite-wing radiographs. It creates the most accurate representation of a tooth image. It refers to the receptor being positioned parallel to the full length of the tooth being radiographed. Advantages of radiographic technique. It can show tooth decay, fillings, gum disease, and types of tumors present in the oral cavity or the bony or hard soft tissue. It can also alert an operator to note the changes in hard and soft tissues. In children, radiographs allow the dentist to see how their teeth and jaw bones are developing. So the operator can predict any malformity in the jaw bones or teeth that will be going to happen in the future. Disadvantages of radiographic method. It has harmful ionizing radiation, and for this purpose both the patient and the operator needs proper shielding and safety. Secondly, it requires expensive equipment. The third drawback of radiographic image is that it is very sensitive to flow orientation. Suppose if a person or the position of the film is not correct, then it will not record the details we require. So this was a very detailed video about the working length, its determination, and different methods from how we can record working length. So I hope you like this lecture, and inshallah in future I will be uploading its third part about obturation. Don't forget to like and subscribe my channel. Thank you.